La resistencia a los antimicrobianos va en rápido aumento, lo que representa un riesgo para todos, jóvenes o ancianos. El uso excesivo e indebido de antibióticos ha permitido que microbios peligrosos adquieran resistencia contra los mismos fármacos diseñados precisamente para matarlos. Son las llamadas superbacterias. Y a nivel mundial, van en aumento. Pero aún hay esperanza. Existe una herramienta clave en la lucha contra la RAM que les puede sorprender: las vacunas. Las vacunas ayudan a dotar al sistema inmunitario de la capacidad de producir anticuerpos frente a los microbios dañinos. Dado que las vacunas ayudan a prevenir ciertas enfermedades infecciosas, hay menos necesidad de recurrir a antibióticos para tratarlas. Con las vacunas, disminuye la carga de RAM, ya sea mediante la reducción directa de las infecciones bacterianas asociadas con la resistencia, o como en el caso de las vacunas contra la influenza, al bajar la tasa de infecciones bacterianas secundarias que pueden ocurrir cuando el cuerpo se debilita por el virus. Al aumentar las tasas de vacunación e innovar con vacunas nuevas, podemos ayudar a disminuir la necesidad de usar antibióticos mediante la reducción de la carga de enfermedades infecciosas. Esta es un arma que queremos de nuestro lado en la lucha contra la RAM.
Buenos dias. My name is Craig Coopersmith. I'm the director of the Emory Critical Care Center. I wish so much that I could be with my friends from SOPEMI today. I look so much forward to the COVID-19 pandemic being over. But until then, I'm excited to talk to you about the pandemic, about COVID-19, lessons learned about managing patients in a pandemic. I have a lot of disclosures, none of which I get paid for. I'm a member of the National Institutes of Health Guidelines panel on COVID-19. I'm not speaking on its behalf, but that's going to make up much of my talk today. I'm an author on the Surviving Sepsis Campaign Guidelines on COVID-19 and co-chair its research committee, including research priorities on COVID-19. And I've also advised the WHO on COVID-19. So I know you know this, but just to put it into context, there have been over 237 million cases of COVID on the day that I'm recording this. There have been over 4.8 million deaths worldwide. And while the United States has only approximately 4% of the world's population, over 44 million cases of COVID have occurred in the United States, with over 713,000 deaths. By comparison, Peru seems to be doing much better, with over 2 million cases and 200,000 deaths. I'm going to be speaking today about guidelines that come from the United States government, from the National Institutes of Health. Again, I am a member of the guidelines panel, but I'm not speaking on its behalf. Everything I'm going to talk about today is readily available, either in the NIH COVID guidelines, where there's hundreds of pages. They've been updated over 20 times and are very real time, or alternatively talking about the source literature. So when we think about therapeutic management for hospitalized patients, it's important to distinguish the severity of the disease between patients who are in the hospital but do not require oxygen, those who require oxygen, those who require high flow nasal cannula or non-invasive ventilation, or those who require mechanical ventilation or ECMO. And I'm going to talk about each of these separately. When I talk about strength of recommendations and evidence, it's important to understand the strength of the recommendation and the rating of evidence. So A is a strong recommendation, B is a moderate recommendation, and C is an optional recommendation. A grade 1 evidence means there's one or more randomized controlled trials without major limitations. A 2A means there's other randomized trials or subgroup analysis of randomized trials. A 2B is non-randomized trials or observational cohort studies. And a grade 3 is expert opinion. So because this changes from country to country, I don't know exactly who would be in the intensive care unit in Peru, and it might actually change between hospitals within the United States. The first group is patients who are almost certainly not in the intensive care unit. And these are patients who are hospitalized, but not on oxygen. And the one recommendation is their panel recommends against the use of dexamethasone or other corticosteroids. The next is for patients who are likely on the floor, but in some circumstances could be in the intensive care unit. And those are patients who are on oxygen, but not high flow, not non-invasive, and not the ventilator. And on these, the options are either remdesivir for patients who require minimal supplemental oxygen, or dexamethasone plus remdesivir for patients who require increasing amounts of supplemental oxygen. Then there's patients who are most likely to be in the intensive care unit, but again, depending upon the ICU and the culture, could be on the floor. And these are patients on high flow nasal cannula or on BiPAP. And here, the recommendations are dexamethasone or dexamethasone plus remdesivir. And for recently hospitalized patients with rapidly increasing oxygen needs and systemic inflammation, in alphabetical order, either add baricitinib or IV tocilizumab to one of the two above options. And if baricitinib is not available or feasible, tofacitinib can be used. And if IV tocilizumab is not available, sarilumab can be used. And then finally, it's simpler, unfortunately, because there's less options for ICU patients, for those who are on mechanical ventilation or ECMO. And here the treatment of choice is simply dexamethasone. And for patients who are within 24 hours of admission to the ICU, dexamethasone plus tocilizumab. So it's important to understand that not a single drug has been shown to be effective across the entire continuum of hospitalization. So going into the simplest paradigm, earlier in the disease, we target the virus, and later in the disease, we target the host response. So as I mentioned before, steroids are a core therapy to be used in essentially all ICU patients. This goes by severity of disease. For no oxygen, again, unlikely to be in the ICU, the panel recommends against steroids. For patients on minimal oxygen, steroids are also not recommended. For patients who are on increasing amounts of oxygen, dexamethasone plus remdesivir or dexamethasone alone. And certainly in the sicker patients, dexamethasone or dexamethasone plus remdesivir for high flow, and dexamethasone for patients who are intubated. What's the data behind this? This was really the first game changer study that came out in COVID. There was a lot of hype about drugs that didn't work. I'll talk about them later. But really, steroids were the first drug that does work. And so this is the recovery trial that came out over a year ago now. It's a large study, a study of 2,100 patients published in the New England Journal of Medicine. And what we see over here is all participants and then broken down by ventilator, oxygen, and no oxygen. And so we see for all comers, dexamethasone decreases mortality. That's the top left. Looking at patients on the ventilator on the top right, in fact, mortality was even further decreased. The biggest spread was the patients on mechanical ventilation, 1,000 of them, and very convincingly showing that steroids are life-saving. On the bottom left, we have patients on oxygen. Note that this does not distinguish between high flow and regular nasal cannula, but still a modest decrease in mortality with steroids. And on the bottom right, for no oxygen, we actually see this flipped rather. Actually, patients who got steroids have a higher mortality. So patients on no oxygen should not get steroids, and the sicker they are, the more likely and the more benefit we're going to see with steroids. And this is just the forest plot for those who'd like to see it this way, showing that all patients, there's a benefit. Mechanical ventilation and oxygen alone, there's a benefit that does not cross midline, and a trend towards harm in patients who do not receive oxygen. Well, there were multiple ongoing RCTs being performed with not only dexamethasone, but also hydrocortisone and methylprednisolone. And when the recovery trial was published, each of these was stopped prematurely because of the feeling that it would be unethical to continue to randomize patients. Impressively, and something we've only really seen in COVID-19, all the groups banded together to perform a meta-analysis of these 7 RCTs. And this was published in JAMA, and this looks at an association between administration of systemic corticosteroids and mortality among critically ill patients with COVID-19. And what we see here is that there is a benefit all comers with subgroups that were predetermined. So mechanical ventilation, yes or no, an improvement in survival. Age, younger or lower, an improvement in survival. Gender, male, female, an improvement in survival. Symptomatic for less or more than 7 days, an improvement in survival. The only place where it's not clear that there is an improvement in survival, but there's certainly no trend towards worsening, is patients who are already on pressors. The next drug I want to talk about is remdesivir. For patients who are on no oxygen, there's insufficient evidence for or against routine use of remdesivir. For patients at high risk of disease, remdesivir might be appropriate. However, as we start adding oxygen, remdesivir is recommended for patients on minimal oxygen, on regular high flow, and a much lower level on patients who are on non-invasive ventilation, and not recommended for patients on mechanical ventilation or ECMO, except for patients who started the course of therapy and then progressed to mechanical ventilation, in which case the course of remdesivir can be completed. It's important to note that this is the only place that there's a significant divergence between the NIH guidelines and the WHO guidelines. The NIH guidelines have been revised over 20 times and have hundreds of pages of recommendations online. The WHO guidelines used a totally different methodology and have only 7 total recommendations. So while the NIH guidelines have many, many more recommendations, of the 7 that they both look at, there's only a discrepancy on this one drug, and that's remdesivir. The NIH guidelines recommend it, but the WHO guidelines recommend against it. Why is that? Well, it really goes back to 2 major studies. In the ACT 1 trial, which was done in the United States, remdesivir was associated with an improved time to recovery in a modest-sized trial, 435 patients who received oxygen supplementation. There was no benefit in high flow, in non-invasive or invasive mechanical ventilation. It wasn't, fewer patients progressed to needing high flow ventilation or ECMO, and in a post hoc analysis, remdesivir appeared to confer a substantial survival benefit in this subgroup. The Solidarity trial from the WHO is significantly larger, and they showed no difference in mortality. Having said that, an open label trial like Solidarity, which was not randomized, which was not blinded, but was open label, is less well suited to assess time to recovery than a placebo-controlled trial. In the Solidarity trial, because both clinicians and patients knew that remdesivir was being administered, it's possible that hospital discharge was delayed in order to complete the 10-day course of therapy. So ultimately, the WHO valued the no change in mortality and recommended against it. And the NIH valued the improvement in time to recovery in a smaller trial, but one that was placebo-controlled. This has just come out in the last week or 2. And this is remdesivir plus standard of care versus standard of care alone for treatments admitted to the for patients admitted to the hospital with COVID-19, the Discovery trial. So this is a phase 3 open label adaptive multi-center randomized controlled trial done at 48 sites in Europe. It's important to note up front that of these, 440 out of the 857 patients were previously reported in Solidarity. And so there's additional information in this new trial, which was a negative trial, but half of the patients had previously been published. Ultimately, they noted no clinical benefit from the use of remdesivir in patients who are symptomatic for more than 7 days and required oxygen support. So how do we put all of this together? It's actually challenging because we have multiple well-done studies coming to differing conclusions. And so ultimately, it is reasonable to look at the Act 1 study and suggest that remdesivir might speed time to recovery. It's also reasonable to look at solidarity and the new patients in discovery that were not in solidarity and suggest that remdesivir does not benefit survival. Having said that, it's important to look in discovery in this trial at this secondary endpoint. Of course, a secondary endpoint should be hypothesis generating as opposed to definitive data. But look at this: new mechanical ventilation, ECMO, or death within 29 days. When patients with moderate COVID, not much difference, 14% versus 16%. Patients with severe COVID, huge difference, 29% versus 51%, with an odds ratio of 0.66 that does not cross midline, and is statistically significant, suggesting that potentially in the right patient population, remdesivir is beneficial. How about adjunctive immune modulators? For patients not on oxygen or simply on nasal cannula, they're not recommended. But for patients on high flow nasal cannula non-invasive ventilation, for recently hospitalized patients with rapidly increasing oxygen needs and systemic inflammation, recommend either baricitinib or tocilizumab. Again, that's in alphabetical order. One is not recommended over the other, to either dexamethasone alone or dexamethasone plus remdesivir. And for patients who are within 24 hours of admission to the ICU, the recommendation is to add IV tocilizumab. Why? Well, interleukin-6 is a pleiotropic pro-inflammatory cytokine that's produced by a variety of cell types. And very early in the course of the COVID pandemic, it was seen that IL-6 levels were higher in COVID patients, and IL-6 levels were higher in non-survivors than survivors. It's complicated because this very well done paper in the Lancet Respiratory Therapy Medicine actually looked at the difference in IL-6 levels between different types of critical illness. And what we find is IL-6 levels are much higher in ARDS, in sepsis, and in cytokine release syndrome than they are in COVID of any type. But the key thing is here, when we're talking about IL-6, we're not trying to block IL-6 in the blood, and these are from the blood. We're trying to block it in the lungs, where levels are quite high. Well, there's two anti-IL-6 receptor monoclonal antibodies approved in the United States, tocilizumab and sarilumab. What's the data on them? So the early studies were actually negative, but these were performed prior to studies becoming standard of care. They were limited by low power and heterogeneous populations, and many studies excluded patients on the ventilator. This is the first major one that was positive. This is the REMAP-CAP trial, and it's an adaptive platform trial for patients in the ICU 24 hours after starting organ support, randomized to receive tocilizumab, sarilumab, or standard of care. And ultimately, the conclusion was that tocilizumab and sarilumab both improved survival. So I mentioned the criteria: age over 18 in the ICU, receiving the respiratory cardiovascular support, and enrolled within 24 hours. This is just to show you that in this adaptive trial was actually a very, very complex design. So patients could be randomized to tocilizumab or sarilumab or no immune modulation or a different intervention or a totally different domain happening simultaneously. But for those who are randomized here, look at the first three trials, toci, sarilumab, and control. What we see is that this is dominantly a trial of patients on non-invasive ventilation, with a modest number also just being on oxygen or on the ventilator, about 10 or 20% on ventilators, and sick patients. The median P to F ratio was 115 to 120. And then we look at the bottom here, probability of superiority to control. we see that both tocilizumab and sarilumab, albeit with a lower number level, the probability of superiority to control was over 99%. We see this for in-hospital death and for organ-free days. For organ-free days, you'll note that it's greater than 99.9% superiority to control. For those who like to see graphs, on the left, we have proportion of survival, and certainly mortality is higher in the top left in control versus the IL-6 inhibitors. And on the top right is number of organ-free days. So red here is bad. That means more time requiring organ support. And you'll see that it's higher in control than with the IL-6 inhibitors. Notably, before June 17th, before the recovery trial, only a small subset received steroids. But after June 17th, which is most of the patients, 93% of patients received steroids. So that's a large trial, but it's not consistent with earlier negative trials in tocilizumab. And so this is a follow-up trial, the recovery trial. And this is a randomized controlled trial of a large number of patients to receive toci or not. This is done in the UK, patients over the age of 18 who had rapid progression of COVID-19, as well as evidence of inflammation with a CRP greater than 75. You'll see here that about half the patients were on either non-invasive mechanical ventilation or the ventilator, and about half the patients were not on either. Probably best to look at the right here. And what we look is for both mortality, that's on the top, and discharged alive, that's on the bottom. You'll see that patients who were randomized to receive tocilizumab had better outcomes. When one looks at subgroup analyses, one sees all participants, they do better. The key thing I want you to note here is near the bottom, the benefit was only seen on patients with steroids. It was not seen on patients without steroids. There seems to be an interaction between tocilizumab and steroids. And when taking all published studies together of tocilizumab, you see a marked improvement in survival that does not cross one. To be complete, I need to acknowledge this study that just came out in the last couple of weeks in intensive care medicine. Tocilizumab and remdesivir in hospitalized patients with severe COVID-19 pneumonia, a randomized clinical trial, that does not show a benefit for tocilizumab. This did not look at inflammation, and so it's possible that tocilizumab only works in patients with evidence of inflammation. But how to put this trial, which is well done, in conjunction with the two previous ones that I've shown you, is still a work in progress. The other major inflammatory mediator is baricitinib, which is a selective JAK kinase inhibitor with known anti-inflammatory profile in patients with autoimmune disease. And unlike everything else, can be given orally. This is a very early trial, looking at baricitinib plus remdesivir for hospitalized patients. Patients were not on steroids in this because this was done before steroids became standard of care. So this is remdesivir versus baricitinib plus remdesivir. The combination was superior in reducing recovery time and accelerating improvement, most significantly, although still modestly, on patients in high-flow nasal cannula. But that doesn't really answer the question, what happens in the modern era when we have everybody on steroids? And so the COVE barrier study came out fairly recently in Lancet Respiratory Medicine, looking at the efficacy and safety of baricitinib for the treatment of hospitalized patients with COVID-19. Their primary endpoint was disease progression, and this was not met. Their secondary endpoint was mortality, and this did show a mortality benefit. So what we see here is none of these patients are on the ventilator. Small number were hospitalized, not on oxygen, but mostly this is patients on oxygen, and a smaller number on high flow or non-invasive ventilation. And what you see is all-cause mortality goes down from 13% to 18% with a very impressive odds ratio and a very impressive p-value. And when looking at different subgroups, all told, it favors baricitinib. As I mentioned, none of the patients in that study were on mechanical ventilation. This data has been presented in abstract form, but is not yet published It was presented at the Infectious Disease Society of America last week. And this is looking at patients who are randomized to baricitinib versus placebo. Similar thing, but these patients are on the ventilator or on ECMO. It is a small study, only 101 patients. But it is provocative to note that baricitinib plus steroids resulted in a risk mortality of 19% at day 28 and 17% at day 60 in patients who are on mechanical ventilation and ECMO. Should we use them both together? The answer is no, because they're both potent immunosuppressives and there's the potential for additive risk of infection. Should we use them without steroids? No, we should use steroids first before deciding whether to add them. Which one is better? We don't know. We have insufficient evidence to recommend one drug over the other. How about other therapies? This is a long slide. All of this is available on the NIH website, and I only want to highlight 2 drugs. The top is hydroxychloroquine or azithromycin. There was a lot of hype about these at the beginning, especially in the United States. And the answer is they do not work. There's strong evidence that they do not work and they should not be used. The other drug that I want to mention is ivermectin. I am well aware of the fact that ivermectin is used in many, many portions of the world. This is based upon relatively poor data, poorly designed studies. We are waiting for strong data on ivermectin. Right now, we state that there's insufficient evidence to support its use, and we do not use it in ICU patients or non-ICU patients in the United States in general. How about monoclonal antibodies? Monoclonal antibodies are not authorized for use in the United States in hospitalized patients. However, they may be available through expanded access programs for patients who have not developed an antibody response, or for those who are not expected to mount an effective immune response. Easier to get convalescent plasma. The panel recommends against the use of low-titer convalescent plasma for the treatment of COVID-19. Recommends against the use of high-titer convalescent plasma for the treatment of COVID-19 in hospitalized patients who do not require mechanical ventilation, based on a well-done randomized trial. The currently published data says for hospitalized patients with COVID-19 who have impaired immunity, there's insufficient evidence for the panel to recommend either for or against the use of high-titer convalescent plasma. However, this just came out in JAMA, effective convalescent plasma on organ support-free days in critically ill patients with COVID-19, done by the REMAP-CAP investigators again, where patients were randomized to receive 2 units of high-titer convalescent plasma within 48 hours in critically ill adults. And ultimately, the study was stopped for futility. The study was stopped early because there were a higher level of severe adverse effects in the convalescent plasma group, and there was no benefit seen to convalescent plasma. So there's really not evidence that we should be using this at all in our patients. How about therapeutic anticoagulation with heparin? There's pretty good data to suggest that therapeutic anticoagulation might be beneficial prior to the ICU. But in the ICU, this study that came out from, again, some of the same groups that I've talked about in the New England Journal of Medicine shows that in critically ill patients with COVID-19, a strategy of therapeutic dose anticoagulation with heparin did not result in a greater probability of survival to hospital discharge or a greater number of days free of organ support. The final thing I'd like to talk to you about is awake-prone positioning. So I know that many of us have been doing awake-prone positioning throughout COVID, but it was unclear whether this was a biased approach or not. And so this study recently came out in Lancet, looking at awake-prone positioning, a prospective trial, collaborative meta trial of 6 randomized controlled open-label superiority trials done in hospitals from 6 different countries. 1,100 patients, large study, ultimately demonstrating awake-prone positioning of patients with hypoxemic failure due to respiratory therapy reduces the incidence of treatment failure and the need for intubation without any signal for harm, with the results supporting routine awake-prone positioning for COVID-19. 3 things I want to show you. It decreases treatment failure. It decreases intubation. It does not change mortality. So this doesn't improve survival, but it decreases the chances that patients will end up getting intubated, a very patient-centric outcome. And then finally, how long do we prone people for? Well, there's no clear data. You see here the number of patients randomized to each group. And what you see is patients who are randomized for longer periods of time for prone ventilation, 8 hours or longer, have a higher chance of treatment success. And so one would suggest that we prone longer rather than shorter. So in conclusion, pharmacologic management of COVID-19 is complex and depends upon the patient acuity. For no oxygen, no treatment is given other than supportive care. For conventional oxygen alone, remdesivir, maybe steroids of increasing oxygen. The sweet spot for most treatments are high flow nasocannula or non-invasive ventilation, where we give steroids plus or minus remdesivir, and for recent hospitalized patients for increasing oxygen and systemic inflammation, add either tocilizumab or baricitinib, and for patients on the ventilator or ECMO, steroids and early tocilizumab. No role for hydroxychloroquine, no real role for ivermectin, no role for heparin in the ICU, but awake proning reduces the need for mechanical ventilation. Again, I wish so much that I could be here with you. I miss my friend SOPEMI from SOPEMI so much. Muchas gracias. I hope we all get to see each other again in person soon.